Dear, dear friends, today we are going to discuss another important topic, interstitial lung disease in childhood. Some of you already heard me talk on interstitial lung disease in infancy, and today we are going to concentrate on interstitial lung disease in childhood. People who are not heard, I think I request you to go and see that video so that you have a better understanding also. Anyway, for anybody who sees also, you can easily understand if I show some of very important slides. What is interstitial lung disease? As the name suggests, these are the diseases that primarily affect the interstitium. What is interstitium mean? This alveoli, capillary, this is the interstitium. Actually, we all thought like that. But these interstitial lung diseases doesn't confine to interstitial alone. It also involve alveoli and distal air spaces. That is the reason why many people uh, prefer the terminology diffuse lung disease. But for better understanding, in my future lecture, I am going to use the name interstitial lung disease only. And if you happen to see the literature, diffuse lung disease means it is also what they mean is more or less interstitial lung disease, but include some other causes also. Coming to the etiology that causing ILD in infancy is differ from adults. For example, in adults, interstitial lung disease means mostly it is smoking related. You may go for IPF, that is interstitial pulmonary fibrosis, or NIP, or that is a non-specific. Initially, they are very difficult to diagnose, or cryptogenic, or like that. There are so many causes in adults. Like that, in infants, the most common cause of ILD is surfactant disorders, or lung growth dysplasias, or the causes that is very peculiar to infancy because the infant ILD occurs during the growing phase of the lung. That is the reason why I already talked this subject as a separate video. Now we will go on to ILD in childhood. This adult topic, I think we may not be very much interested in adult ILDs. So today we can concentrate ILD in childhood. I think this is only for a convenience. For example, what that has been started as infancy, you may miss it, you may diagnose in childhood also. So don't think that it is strict compartments, and it is only for a convenience. Coming to the pathophysiology, look at this is alveoli. Normally the oxygen comes from here, goes to the vessels, capillaries. From here carbon dioxide goes like that. Somehow in ILD, there is a damage to the alveolar epithelium occurs. Wherever there is an injury, there is an exaggerated. In our body, it is a rule. Whenever there is injury or insult or infection, there is a big immune response. And a lot of inflammatory cells come for a rescue, of which the most important is the neutrophils. Once that battle over, it is a fibroblast they lay down the collagen, then repair. But unfortunately, in interstitial fibrosis, it is it is become very thick. Instead of a normal healing fibrosis, it becomes a very big scarring. This scarring or scar formation that happen in the interstitium impede the normal exchange of oxygen and carbon dioxide. Actually, carbon dioxide is the one that is 20 times more diffusion capacity than the oxygen. That is the reason why carbon dioxide is not affected. In most of the ILDs, this is oxygen exchange. Oxygen perfusion becomes defective, and the child will go for progressive hypoxia and other symptoms. Coming to the clinical features, Most of the ILDs start with cough, unexplained cough, irritating cough. That cough may not respond to any cough syrups or anything like that. And people also or children also develop some tachypnea initially. After that, they will go for exertional dyspnea, then typical respiratory distress symptom. In neonatal ILD, more than a cough, child start presenting with a severe respiratory distress from the day of life. And again, on examination, you can see some children are developing a clubbing, failure to thrive, or typically they develop Velcro crackles. What is Velcro crackles? You all know Velcro, no? In our shoes and all. Once it's if you open that, it will produce a typical sound. That is what in a ILD there is a stiff lung. The alveoli get collapse. So during inspiration, you have to mount lot of inspiratory efforts to open the alveoli. And suddenly, one point of time, it typically opens with a sound. That is what Velcro crackles. So I think in my those days when I happened to manage ILD, I always auscultate Velcro crackles. I am fortunate to hear this also. Once you make a, I think these are the ones, if you have an experience, don't miss it. Child slowly grow for a progressive hypoxia and go for an interstitial lung disease. Particularly, these are the children go for a restrictive disease. Actually, there is only few conditions called obstructive lung disease in pulmonology. Name the few. 4 conditions only I can say. Namely asthma, bronchiectasis, or COPD, bronchiolitis obliterans. These are the only 4 or 5 conditions. All the other conditions, including ILD, they go for a restricted lung disease. And finally, if you do not diagnose in time or you are not able to manage, they go for respiratory life. Actually, ILD is the one condition known for highest morbidity and mortality. I think it's one of the paper, very good paper done by Langston. He published this in 2009. Actually, he had an opportunity to do a lot of biopsies, lung biopsies, surgical biopsies, and he classified ILD into 4 or 5 groups. He grouped as a surfactant dysfunctions, then ILD is connected with the systemic diseases, and ILD happening in the immunocompetent host, then environmental exposures that causing ILD, particularly hypersensitive pneumonitis and eosinophilic pneumonias, aspiration, all these things. He done a very good work, and he also find out some of the drugs are implicating with ILD, particularly the bleomycin, nitrofurantoin, methotrexate. I think it's a very good paper. Anybody interested, go through that. As I already said, for a convenience, I am approaching ILD as these 2 boxes. The first, this left side box is the one ILD happening in infancy predominantly, and the right side box is the ILD happening in childhood. Actually, it is not a strict compartment. I already said it is only to better remember. So already I talked this as a separate video, that is ILD happening in the infants. Please go to that. And these are the conditions. In infants means surfactant and some peculiar conditions like neuroendocrine hyperplasia of infancy and pulmonary interstitial glycogenesis. Then alveolar capillary surface, a dysplasia with mis or malalignment of the pulmonary veins. These are the surfactant problem. Mostly surfactant problem followed by some of the lung growth deformity. These are the ones that present as ILD in infancy. Whereas childhood, actually same conditions may happen. You happen to diagnose during childhood also. In addition to these conditions, you can also diagnose this Langerhans histiocytosis, pulmonary hemosiderosis, hypersensitive pneumonitis, and JAA, sarcoidosis. All these conditions are typically, I think, depending upon the severity. Some of the, if you happen to manage the child very early, they may have better life. Otherwise, unfortunate children, they go for ILD as a complication of these diseases. This is what I told during my last lecture. I talked about that. It is ILD in infancy, most of them because of the surfactant dysfunctions, namely surfactant B, C, APCA3, and NKX2. These are all I explained in that other video. And some conditions are typically happening in infant. These are found to be a better prognosis that also I talked. And I also give an example for a developmental disorders associated with the lung growth abnormality. Typically, it is called as ACD-MPA. These are all lung biopsy findings. I think we are not going to discuss all these things because these topics I covered in the last video. Actually, I had an opportunity to do a lot of work during my professorship at hospital, and I happened to see many sick ILDs I happened to treat, and we published this as a paper also. I during the time 4-year period, I able to follow 16 cases, and it's a very high mortality, and most of the children lying 2.5 years and all, and I done a lot of most of the children are subjected for BAL, and we find out neutrophil is a very, if you happen to see ball neutrophilia, you have to think of ILD. I think this has we present as a paper. With the background knowledge, I am going to tell some of the cases later I followed also, and in this lecture, I may not be covering all these ILDs. ILDs occurs as a complication of all these diseases. I think it's very difficult to cover all these things. Probably few conditions I can talk with you because I had an opportunity to treat these conditions and I share how we manage these conditions and all. This is a 2-year-old child actually brought in a very sick child. Actually, this child been treated by a general physician, and he admitted 3 times in 3 different hospitals. Very sick looking child, dyspnea, cyanosis. Can you see the figure 9? You can see the cyanosis, and it is something like a pneumonia like picture with a with all the other things are all normal, and they brought only one CT. The CT shows cysts. Can you see this irregular cyst? I think this make me to think of one particular condition. And before that, if you happen to see any cyst, what are the differential diagnoses? That is what the usual question. Actually, if you see cyst, I am not talking about the cystic lung disease. Congenital cystic lung disease are all different. Here is acute child, normal child developing a cyst-like lesion, and think of 3 causes. If the child is having a irregular cyst, actually it's like this. Think of Langerhans cell histiocytosis, that is LCH. There are another conditions. Typically, it will confuse. It has a differential diagnosis, but it typically happen in a older adults, particularly in women. The condition is called lymphangioleiomyomatosis. This is a one condition because being a child, I think this is automatically ruled out. Sometimes interstitial pneumonia, there is a lymphocytic interstitial pneumonia, do present with some sort of the cyst, and they also associated with chronic lymphadenopathy and all. So, if you happen to a child, sick looking child or acutely ill child, suddenly becoming abnormal, getting a lot of cyst, irregular cyst or regular cyst like null, you have to make 3 differential diagnoses. Actually, what we have done, since we don't know the etiology and all, and myself, my friend, we have decided to go for biopsy. And fortunately, we have cryobiopsy. This child subjected for cryobiopsy, then this is a biopsy specimen, and it is going to be it was positive for immuno. We have done an immunohistochemistry, and it is positive for CD1A antigen. It is called Langerhans antigens, and it is confirming LCH. Actually, we made a diagnosis, and it is really we all very satisfied. And immediately after making diagnosis, the child was started with the vinblastine prednisolone, and the child started improving. So LCH is one condition. that typically go for ILD. And sometimes if you make a diagnosis, we can make the child have a better life. This LCH is the one affect any age, not only young age or child or adult. Actually, and the incidence, if you go that, it is 5 per million, and there is a typical proliferation of dendritic cells happen, and being a multisystemic disease, it predominantly present with the bone lesions, and one of the manifestation is a pulmonary manifestation. Actually, if you go into the literature, this LCH is being called as histiocytosis X, eosinophilic granuloma, Letter disease, Hashimoto, Pritzker, and Anschüler. So many names are given there. Don't confuse. Nowadays, after the consensus, we do not use all these names, and we are going to use only one name, that is called LCH, that is Langerhans cell histiocytosis. Another case, it is exactly opposite to that. This is a very cute looking child, 2-year-old, and child is presenting with cough and hemoptysis. Hemoptysis is around 5 to 10 ml 3 times, but child is also little anemic. Actually, this is normal, but actually the child is admitted and given 2 times blood in the form of PRBC, that is packed red blood cell and all. And if you look at the blood picture, hemoglobin is 4.9. Typically, serum iron and ferritin are all very much diminished. This child brought with us, and the X-ray shows infiltrates, bilateral infiltrates and all. So, on CT is taken, look at that, CT shows bilateral densities, and you can see consolidation like foundation on both sides, and you can also see some of the ground glass appearance and all. Actually, what there is a consolidation, ground glass, and basal dominance, all these things are highly suggestive of some hemorrhage, and actually that made us to go for bronchoalveolar lavage. Whenever you suspect bronchoalveolar lavage, we can do BAL, and we can find out hemosiderin laden macrophages. Whenever there is a fresh bleeding is happened, within 2 days, your macrophages is going to engulf, and that can be easily reported by BAL and all. And the BAL shows hemosiderin laden macrophages. Sometimes it is called siderophages, and this child is confirmed as pulmonary hemorrhage, that is idiopathic, because we ruled out other causes. And initially we thought it is an idiopathic, because idiopathic pulmonary or pulmonary hemosiderosis is a condition typically present with a triad. One is hemoptysis, iron deficient anemia, and pulmonary infiltrates. And if you are not able to find out any other cause, sometimes pulmonary hemorrhage could be due to good posture, sometimes it may be due to vasculitis, sometimes unconsociated vasculitis. If you are ruled out all these things, then you can call it as an idiopathic pulmonary hemosiderosis. That's what made a diagnosis. And to our surprise, when I go into the history, the child used to consume lot of milk. The child is literally lives on milk and milk related products, particularly biscuits, cheese, butter, consumes more than 500 to 700 ml of milk per day. So we thought, why not we'll go for a prestating antibodies, that is cow's milk protein prestating antibodies. It's found to be positive. Then actually it is found to be a subtype of pulmonary hemosiderosis, that is Einer syndrome. Whenever the pulmonary hemosiderome is secondary to cow's milk protein, then we can call that condition as a Einer syndrome. And the child was presented with the prednisolone, treated with the then child's condition become improved. After that, child is advised to stop milk for some time, discontinued milk for some time. When they come for a review, the child is totally normal. X-rays are normal, CDs are normal, and they were also very happy, because in my follow, I happened to see many idiopathic pulmonary hemorrhage, And when the history is suggestive of very high consumption of milk, I always advise to stop them milk for at least 3 months, because it is a treatable condition. We don't know cow's milk protein allergy itself a big chapter. And these are the milk proteins. They produce a lot of autoantibodies, and that targets your capillary, your alveolar membrane, thereby causing a disease and all. So it's simply, if you happen to have get such a history, you stop the milk protein, and they typically, some of the, I'm lucky to treat 3 or 4 children. After stopping the milk, they totally become normal. And now we can stay. You can actually, one child has been done by a lung biopsy also, and later they came for a pulmonary hemosiderosis, and the history shows is a very consumption of milk and all. After stopping the milk, the child becomes all right. Bronchial lavage plays a very important role in the diagnosis of ILDs, because if you document lipid laden macrophages, you can say NA is aspiration, because we all know aspiration is one of the condition typically goes any child recurrent aspiration or recurrent micro aspiration, and typically alveolar injury may lead to ILD. So there your BAL if shows lipid laden, you can document that is a lipid pneumonia causing ILD and all. Like this case, if you are able to document hemosiderin laden macrophages, yeah, there is hemorrhage is happening, and such a conditions, and if you confirm the diffuse pulmonary hemorrhage, and you have to work out for further causes, and like already I said, sometimes it may be due to part of um, vasculitis or ANCA associated vasculitis and all, and you have to necessarily rule out. As a previous cases, sometime I'm going to talk some of the cases how your BAL going to help us in making a diagnosis of sarcoidosis or hypersensitivity pneumonia. Actually, if it is BAL shows majority of CD4, then your it is maybe a sarcoidosis, highly suggestive of sarcoidosis. Or if the ratio, or if it is CD8 is found to be more, then you can, it is highly suggestive of hypersensitive pneumonitis. And if it is so more than 25% eosinophils and all, it shows acute eosinophilic syndromes and all. Sometimes the milky appearing fluid is the one that make you to think of alveolar proteinosis. Actually, this child also we happen to manage the alveolar fluid. Actually, BAL exactly resembling a milky one. Is a type of disease, and it is also related to surfactant. There is a defective surfactant. Defective clearance of the surfactant go for pulmonary alveolar proteinosis and all. So the knowledge about the strains is very important. Even if you do a ball, you have to communicate with the pathologist what do you want. Sometimes the names are changing. Some people want to use Sudan red, or some people are using oil red. So that is the reason why if you want to make confirm lipid pneumonia, you ask him to go for oil red. The old terminology is Sudan red. Similarly, if you want to confirm pulmonary hemorrhage, go for Pearl's Prussian blue staining. Actually, many times some people will call as a Pearl stain, some will call as a Russian blue stain. So I think better to, I think you have to know both are same. There is a Pearl's Russian blue staining. You have to tell, you have to discuss with them. And like that, sometimes PAS strain is positive in alveolar proteinosis. And ball neutrophilia always says there is a candidate of underlying pulmonary fibrosis. This is another child, 9-year-old. This is a very, actually, this child brought with a complaint of initially fever, after that cough. This is something is a very loud barking cough, something like a very big cough, and he never stopped coughing. And auscultation showed some sort of a crackles and wheeze. Child has been repeatedly nebulized and admitted in various hospitals, and he is having a little less of SpO2 also at times, whereas other investigations are normal. His immunoglobulin is normal, sweat chloride is normal. Actually, they say the child was not typically normal 6 months before. They are developing all these things only for the past more and more symptoms for the past 3 months. And your X-ray may not be some infiltrates, but CD typically shows there is a ground glass. Okay, and also reticular changes also seen. Some of the ground glass seen. Sometimes some areas may have some sort of a consolidation and all. So we done a bronchoscope because what is happening in the child we don't know, and to our surprise, lymphocytes is elevated. We should know what is a normal, like a blood count. What is a normal cytology? You should know. Here the lymphocytes is elevated. What does that mean? When there is a lymphocyte is elevated, it is a suggestion of some hypersensitivity pneumonia. Okay, it is a hypersensitivity pneumonitis. Then later I verified the child is there recently. The child was given parakeets. About 6 parakeets was given as a presentation, and he used to play a lot because it's a actually every day the child started playing with the parakeets for hours together, and he started developing uh, and bird antigen causing a culprit developing hypersensitive pneumonia. So that is the reason why the lymphocytes is increased, and even the ratio CD4 CD ratio also is reduced. So this knowledge is very important. Hypersensitive pneumonitis, very difficult to make a diagnosis because actually a lot of consensus been happening with the hypersensitive pneumonitis, and wherever possible, the most important is the clinical features. Or you have to go for ball. Wherever possible, you can utilize this. And HRCT one is highly suggestive, and many people believe HRT plays a major role in the confirmation and all. Of all that, exposure identification is very, very important. The reason uh, consensus says that the most significant diagnostic tool in the hypersensitive pneumonitis is a elicitation of detailed environmental exposure history. Sometimes the child may be get exposed to parakeets or pigeons, and that is sometimes the child may exposed to some of the they may be working very near to the factory where they are making a lot of chemicals. All these things are all very important. In old people or adult people, you can ask pneumoconiosis. What is a occupation? Whether they are implicated, whether they are closely working with asbestos or silicasis, all the or coal mine. All these things are all going to hypersensitivity pneumonia and all. What they say, avoidance of inciting antigen plays a very important role. Whenever strongly suspect hypersensitive pneumonitis, you advise them to get away from the inciting antigen. That itself is not only a diagnosis, confirmatory diagnosis, but also make them to get away from this illness. Because for that, you have some knowledge about the cytology also. I said it's a normal cytology. Normally, like a blood count, normal your blood is something like a polymorphs or more. Polymorphs 60% or lymphocytes 30%. The rest of the cells is 10%, but though it varies from the age to age. Here also, alveolar macrophages is the maximum. Actually, in lung, the most important cell is the alveolar macrophages. We never see any neutrophils here. If at all, is 1 to 2%. Next to alveolar macrophages, 10 to 15% here is lymphocytes. I think this cytology gets altered. It shows the child has some problem. That is increase of neutrophils, highly suggestive of ILDs. Increase of lymphocytes, again I already said about the hypersensitive pneumonia. Like that, this knowledge is very important. I already said there is a consensus on hypersensitive pneumonitis, and the scientists now feel that sometime before we call it as a acute, subacute, chronic, and all that terminology they change now. Then now they want to call it as a non-fibrotic or fibrotic, because most of the ILDs in children are non-fibrotic, and only after a long time or a long continuous exposure they go for a fiber optics, fiber optic stage and all. And again, this chapter is very important because one reference says that of all ILDs in children, hypersensitive pneumonia constitutes the maximum. But unfortunately, the diagnosing the condition is very difficult. So it is not, you have to know about that, you have to do some. And the most important thing is in children, the hobbies, like what our child may get exposed to parakeets or birds or parrots. All these things, these droppings of these birds, they get exposed and they go for a hypersensitive pneumonitis. Actually, unlike an asthma is a condition where it's a type 1 hypersensitivity plays a very important role. Whereas in hypersensitive pneumonitis, it is a type 3 and type 4 hypersensitivity plays a lot of role and all. And I already said, by looking at the lymphocytes, you can make a diagnosis. In hypersensitive pneumonitis, it is a CD4 count increases and thereby causing the ratio comes down. Actually, the normal ratio of CD4 CD8 is 1 to 1.4, something like that, and here this ratio get reduced and all. So whenever the child presenting with a chronic cough that doesn't fitting into the asthma and all, or the cough is very typical, there is no typical wheeze, child is relatively normal in the night. In such a situation, we have to ask about the exposure history, exposure to environmental allergens. And if you talk with the mother or parents, at least in 60% of the children you get the ST and all. This is another condition that making child to go for ILD. This is a 10-year-old child presenting with a dry cough, respiratory distress, and he also developed a joint pain, and recently he has been worked out for joint problem. And because of his rheumatoid factor positive and ACC P positive and all, they made a diagnosis of hypersensitivity. There is a rheumatic problem. What is anything strike in your mind? What rheumatic condition you can think of? Yes, it is a juvenile idiopathic arthritis. Sometime before, we call it as a juvenile rheumatoid arthritis. Nowadays, we call it as a juvenile idiopathic arthritis. And again, this child also developing some sort of lung problem and continuous cough, respiratory distress, and his CT shows bilateral infiltrates, highly suggestive ground glass. So with this background, what do you think of? Child is already a rheumatoid arthritis and is now having a prolonged cough, distress, and CD showing ground glass. Any other answer? Yes, it is found to be a juvenile idiopathic arthritis with interstitial lung disease. Actually, among all the connective tissue disorders, it is a rheumatoid arthritis is the one in childhood found to go for an interstitial lung disease and all. Few points about juvenile idiopathic arthritis. Originally, it is called as a juvenile rheumatoid arthritis, and it is the most common type of arthritis in children. And a child typically present with a symmetrical arthritis. Initially, they present with a smaller joints, and depending upon the involvement of joint, it is either classed as a oligo or polyarticular arthritis and all. And most of the children develop uveitis also. I already said you have to work for rheumatoid factor and ACCP and all. And what is Felty syndrome? Actually, most of the postgraduates are interested to know some of the syndromes. The one syndrome that connected with a juvenile idiopathic arthritis, it is called Felty syndrome. Here, the child typically have the triad of symptoms like rheumatoid arthritis, splenomegaly, and granulocytopenia. I think sometimes this may be asked in the exam also. Coming to another condition, it is called organizing pneumonia. I am not having the typical case presentation. I do want to share some of the newer newer ideas about the organizing pneumonia. Previously, we called this as a BOOP, that is bronchiolitis obliterans organizing pneumonia. And this terminology is outdated now. We should not use BOOP and all. And you should use only organized pneumonia. And or if it is able to know some causes for organizing pneumonia, then you can call that as organ. If you do not find out any causes after extensive investigation, then the condition is called as cryptogenic organizing pneumonia, COP, either OP or COP. Actually, this condition is relatively common because it is these conditions may be caused by extrapulmonary conditions like many infection. Adenovirus may be implicated with this sort of organizing pneumonia, or even mycoplasma is implicated with that. Sometimes drugs are implicated with organizing pneumonia, even radiotherapy, autoimmune disease, some oncological condition. All these things are all goes organizing pneumonia. And if after extensive work you are not able to make a diagnosis, you put the diagnosis as a cryptogenic organizing pneumonia, but don't call it as a BOOP and all. Some of the pulmonary conditions also produce organizing pneumonia, particularly the pneumonia and vasculitis, all these conditions and all. This one thing I got it from the literature. Organizing pneumonia can present like any radiological or presentation. Sometimes it have a typical consolidation, sometimes it have a ground glass, sometimes nodules may be the initial presentation, or band-like opacities might be the initial presentation and all. Sometimes typical subpleural fibrosis may be there. All these things could be possible, and even atoll sign. Some people call it atoll sign, and some in the examiner also sometimes what is atoll sign and all. Actually, these are the findings typically go with the cryptogenic organizing pneumonia. And initially, if you happen to see such a picture, you have to follow the child. And what is atoll sign? Atoll sign is a one, it is a reverse to halo sign. We all know halo sign is the one that typically happens in a fungal balls. Following there is a old treated TB lesions, cavity lesion, some fungal balls may appear like that. That is called halo sign. Here it is a reverse of the halo sign. In halo sign, there is a central consolidation followed by some sort of a things on peripheral hyperlucency and all. Here the central lucency will be there, ground glass will be there, and it is surrounded by the consolidation. Actually, atoll sign is the one, it may be asked in the exam also, and atoll sign is typically goes with organizing pneumonia. I think it's a very, very interesting child. Recently, probably 5 to 6 years before I saw the child came from a very far east of India. Actually, the child is around 3-year-old, presenting with a cough, weight loss, poor appetite. Actually, considering this typical presentation, it is typically present like a tuberculosis. The child already treated for tuberculosis also, and no improvement. And they brought with one X-ray. X-ray shows perihilar or bilateral infiltrates and all. But they add a bunch of X-ray. One of the X-rays that is taken recently, it is behaving in a little different way. You can see small mottling like that. Actually, when compared to these X-rays, it's totally different. Actually, after about 6 months, the child started developing this sort of the nodules. What is a differential diagnosis? Miliary pattern can be caused by tuberculosis, that is miliary tuberculosis, or sometimes interstitial lung disease, or it may be due to tropical eosinophilia, silicosis, sarcoidosis, fungal infection. All these conditions may produce, but it doesn't stop with the miliary mottling alone. If you look at that, can you see that it is not miliary, it's something more than that. Something like it is not typical module. You can see what is that? I'll show that. If you look at that, you can see the basal things are all there. What is that? Can you see? It is not typically mottling, it's something more than that. What is that? Calcification. Yes, anybody who thought of calcification, you are correct. It is a more than a mottling. There is a calcified micronodules are seen all over the chest, and I think this sort of the typical presentation. That is calcified micronodules with a ground glass opacities, highly suggestive of pulmonary alveolar microlithiasis. Actually, this is a very rare condition, but somehow recently we happened to get about 4 to 5 cases, and actually, when I go on to the literature, there are some countries it is very common, particularly Turkey, China, Japan, India, Italy. All these conditions, the pulmonary alveolar microarthritis is reported, and we are able to follow some of the conditions. And later we found out it is because of the genetic mutations. The mutations happening in SLC34A2 gene, and that is the reason. Actually, the if you make a diagnosis of microlithiasis, all the family members should be screened, and that is very important. It is an autosomal recessive condition. I think it's a progressive condition. Though it is a slowly progressive condition, finally it may end up in ILD, and there is no effective treatment for the child and all. Coming to the diagnosis, I already said that these are the typical clinical features. I think clinical evaluation is very important. Child will be presenting with a clubbing, and you can able to see auscultate velcro crackles, progressive reduction of SpO2 and all, and you can do all these investigations. Actually, all these investigations may be done by even general pediatrics nowadays. And typically, if you have suspect, you have to go for a bronchoalveolar lavage. Actually, bronchoalveolar lavage I can call as a liquid biopsy. I am showing one of the distinct advantages with that. And in younger age group, think of mutation, surfactant mutation, and you go for either NGS, that is next generation sequencing, or WGS, that is whole genome sequencing and all. Out of all, the most important thing is in the diagnosis of ILD is a high resolution CT. What is high resolution CT? High resolution CT is the one taking CT at thin sections, 1 millimeter distance. And I think this is a very important one. Actually, they take thin section at the interval of 10 millimeter. If you see every slice, there is a 10 millimeter distance, and they make a thin section of 1 millimeter. And it is a particular type of CT that is called HRCT that picks up ILD very early, and you can see all these findings, namely ground glass, reticular appearances. Sometimes subpleural changes may be there, but it takes long time to appear, and basal dominance, air trapping, some mosaic. All these things are all. Sometimes when child is going for a fiber optic stage, you can see the traction bronchiectasis, honeycombing and all. I think HRCT, why we order mean we can pick up ILD very early because it show typically reticular and ground glass and all. That's a reason why we are going for a HRCT. Look at the HRCT. Actually, this is a ground glass. Ground glass, I am telling how to differentiate from the consolidation and all. This is a reticular fibrous. Can you see that? Something like a lace work. Actually, the entire alveoli, all that fibrous, the walls of alveoli, and also septal thickening is happening here. That's the reason why this lace-like picture started appearing. And it is also one of the evidence of ILD. Sometimes typically the septal thickening and traction bronchiectasis may happen. Actually, it's a progression. Initially, you can get a ground glass. Later, it may go for this sort of reticular changes. Then it will go for so many other mosaic pattern and septal thickening. All these things are all is depending. It all depend. It all what is the stage that you are going to see the child. How to differentiate consolidation versus ground glass? It's very important one. It's exam question also. Sometimes the ground glass opacity means you can nicely see the bronchovascular markings. It's only an illustration. Look at the ground glass or consolidation. Consolidation means the whole alveoli are filled with exudate. So you cannot see any bronchovascular marking. Whereas in ground glass, here the alveoli are filled with only inflammatory cells, not full edema. That's the reason why in ground glass we can see the underlying bronchovascular markings, but that is not possible with the consolidation. Now we are going to the ILD treatment. Probably ILD treatment, I think one or two slides only. But the most important thing in the ILD is the oxygen. And in my tenure, I have treated many child, and a majority over the years they require oxygen. Sometimes you discharge the child from the hospital with the oxygen. That is called ambulatory oxygen. And you have to see the child should get adequate calorie and all. You have to monitor the SpO2. And these children, when they go for a viral illness, the problem get exaggerated. So they have to get repeated admission and all. Very rarely they go for NGT feeding and all. Coming to the drug, the most important drug in the management of ILD is the corticosteroids. You all know that. And there are some centers are very keen in treating these children, particularly in the acute problem. When they present as acute ILD, they do want to use methylprednisolone. The methylprednisolone used in the dose of 30 milligram per kg. It is given for 3 days. And like that, every month it get repeated. At least 3 months you have to go like that. Some people, if you go to the body square, they have to use methylprednisolone 300 milligram per meter square. And same thing, it's more or less works out same thing. You can use methylprednisolone, which it's also found to be a very good drug. And every month you have to give 3 days. Then you have to go at least 3 to 6 months. Some people are 3 months. Some people you have to go for 6 months. It all depend upon the response. In centers where there is no facilities and all, I think in my setup, I treated a lot of children with the oral prednisolone. To start with 1.5 milligram per kg for at least 3 weeks. Initially you have to 6 weeks you have to give a full dose. After that it can be reduced. Some child need this sort of a this maintenance therapy for a long time. You don't know. It all depend upon how the child responds, and it is every child differs. It all depend upon at what stage you stay. Once the child is started developing a severe fibrosis, even your corticosteroids may not help. In the initial stages, it plays a very good work and all. And sometimes we necessarily use some corticosteroid sparing drug also. And I think maintenance therapy may go for weeks or months or even years also. Sometimes you can stop and see the response. And sometimes child may get back the symptoms. We can restart and all. Sometimes we used to use that steroid sparing drugs like hydroxychloroquine. Hydroxychloroquine is, I think, in my experience, it's really a good drug, and hydroxychloroquine is a less toxic metabolite of chloroquine. And only thing is, when you use that drug, you have to monitor ocular adverse effects. That is the only thing. Otherwise, it's a real good drug, and it has a potential anti-fibrotic properties. It's a very cheap drug, and you can go for 5 milligram per body weight and 2 divided doses and all. In my tenure, when we happened to treat, I have treated a lot of children with these drugs, and thereby you can spare. It is a steroid sparing effect and all. And these days, now in adult, they use many drugs like ninitedanib and pirfenidone. All these drugs they are using. In my experience, I use a lot of hydroxychloroquine. I shown one of the child coming for follow-up. Few child, when they go for some sort of a remission, that symptoms become worse and all. I put them on hydroxychloroquine for at least a month or 2 months. They become less. Their symptoms will come down and all. This is a very good drug. And again, ILD is not a very simple one. I only covered only some in your exposure related. I told about the bird flu lung disease, but that is happening in a child, and it can be happen on exposure to the organic or inorganic. See, sometimes many adults may develop pneumoconiasis, and finally it may lead to ILD, particularly when they get exposed to coal, silica, beryllium, or even radiation is one of the cause for pneumonitis, finally go. Some other drugs are implicated with ILD, not only in adults but also in children. The most important is amiodarone, nitrofurantoin, methotrexate, and all. In the connective tissue or autoimmune problem, I have shown a very typical example of how a child with rheumatoid arthritis going for ILD and how you treated the child and all. But these are the other conditions. Sometimes polymyositis, dermatomyositis also in childhood we go for an ILD and all. The other conditions are given here. Coming to the adult, I think we are not discussing because it's a really adult problem. Among the adult, the most important thing is a smoking related. And if you do not able to make a diagnosis, that should be placed as idiopathic pulmonary fibrosis. Sometimes the adult symptoms may be very, very minimal, non-specific. You can put them on non-specific. Sometimes you are not able to know the cause at all. You can call it as a cryptogenic. And typically anything that occurs after smoking, we can go for a respiratory bronchiolitis, interstitial lung disease and all. And sometimes acute picture is called as acute interstitial pneumonia. I think this dyschromatic is the one, it is also implicated with the smoke and all. I think ILD is a very big chapter. Sometimes it may be occurs after a granulomatous disease like a sarcoidosis, or granulomatous with vasculitis like a sometime before we called as a vigorous granulomatosis. That is called, nowadays we call it as a granulomatous with the polyangiitis. It is also occur sometime while treatment of asthma. They may go for ILD, and these are our vasculitis problem and all. It is nothing but a eosinophilic granulomatous with the polyangiitis. Sometimes it is called Church-Strauss syndrome. And even I happen to treat one of the acute eosinophilic pneumonia. We don't know, some children are typically developing huge number of eosinophils both in the blood as well as in the ball, and any ball and child's typically presenting with a respiratory distress and all. And if you happen to see, the ball may show more than 25% of eosinophils, that confirms eosinophilic pneumonia, and these children are typically respond with the corticosteroids. I think already I have shown the example of pulmonary angle cell histiocytosis going for an ILD, and this condition may happen at any age. That you have to have it can happen in a child or even an adult or even an adolescence and all these kind. So ILD is a very, very broad topic, more towards a adult. Most of the smoking related conditions you have to treat, or it may be due to autoimmune problem, or it may be due to medication and all. I think I already given some examples also. These are the things I talked. Whenever you happen to see a adult with ILD, these are the conditions. Just now I have been telling that. And in my tenure, I happen to see non-specific interstitial pneumonia, and lymphocytic interstitial pneumonia is typically happen when along with the AIDS and or HIV related conditions and all. I think this knowledge also you should know. In a summertime adolescence, probably we happen to see a child with 25 to 30 years and all. You need to have these differential diagnosis in your as a part of your diagnosis. See, this is a very interesting slide I saw in one of the net. What they say, some ILDs are typically happening in the child, some are typically happening in the adult, but there are some conditions that even under overlap. The particular age, you can get both the ILDs. See, for example, in adolescence and all, you may have, I think this sort of overlap could be possible. That's the reason why many people say that if you are not able to make a diagnosis of ILD, go for a biopsy. That's what that say that. But if you typically make a diagnosis of ILD with HRCT, and all the other features are suggestive of ILD, and these children can be even without a biopsy can be done. Why I am telling is, if you do a biopsy, it may not be a representative sample. Even for a biopsy, you have to take biopsy from two sides. And sometimes surgical or biopsy is very difficult. You have to go for a only a video assisted bronchoscopy, video assisted biopsy and all, bronchoscopic biopsy, or sometimes video assisted thoracoscopic biopsy is maybe very useful and all. But most of the times you can make a diagnosis of ILD both in children and adult without biopsy, and there is a overlap also. I think it's the last slide. Whenever you happen to, I think when you, most important thing is ILD is high index of suspicion. If you do not think about the disease in your mind, you will totally miss the biology. And again, making the early diagnosis is very, very important. I already said if child is a newborn or young infant, think about the surfactant problem. Some of the surfactant mutations or lung growth abnormalities go to ILD, and over the age, many connective tissue problems or autoimmune problems, or sometimes LCH, or even hypersensitive immunities, all these conditions present as ILD. And again, you have to go, the typical history is very important because some of the conditions even go as a dominant. So sibling death may happen in the child, that is very, very important. And in newborn period, your genetic testing plays a very important role in the diagnosis. But overall, you make a diagnosis of HRC, make a diagnosis of ILD with HRCT, and lung biopsy only in selective situation and all. And in childhood, the one drug that is miracle in treating ILD is the corticosteroids. Only thing is, these children should be benefit with the corticosteroids with the stipulated dose, and after some time it has to be stopped, and you have to follow this child with a very minimal dose for a long time. I think I have given all the enough message relating to ILD. Probably in my lecture, if possible, we'll talk about the other parts of ILD in later video. People who are not seen the ILD of infants, I already given a ILD about the ILD happening in infancy and all. Please go through that. If you happen to hear both the videos, you have a very full-fledged picture of ILD that is happening in childhood. Thank you very much. We'll see again.